few doctors here. Most of the speakers are professors, and I'm certainly not that. And in the program, it says I'm employed by the University of Bristol. I'm not. I am a clinician. I have large numbers of patients. And I treat with all DMTs, apart from one, which I can discuss later. Disclosures, I think, when debates are incredibly important. But we're talking about treatments. I am hopefully receiving an honorarium, but maybe not at the end of the talk. We'll see. I have received payments for talks by a number of different companies and ad boards, which I really enjoy because I get to meet my colleagues from around the country. We get together and have a good chat and find out if we're doing the same thing to try and reduce variation. I'm trying to work out how much I've been paid over the years, which is also very important. I do about 2 or 3 talks or ad boards a year, so probably about £3,000 to £4,000 a year over the last decade. So not insignificant amounts of money, and I think that's very important to consider when you've got a speaker in front of you. And I also been a guest, a very privileged guest, to go to the AAN and ECTRIMS for many years with a variety of different pharmaceutical companies. And I'm very proud to say that by doing that, I've never, ever taken any NHS money to travel to any of those conferences. So that's how I can justify going to those conferences, which I, again, find extremely useful. But disclosure's very important, talking about drugs. You can only be an ogre if you're going to argue against treatment. Well, why on earth would you argue against a treatment? Treatment per se is going to benefit the patient. So therapies are a good thing. So in the media, you're going to be portrayed as an ogre, or as I'm portrayed by many of my fellow neurologists in the UK, as an old, grumpy man. And I'm probably well qualified for that. Now, I'd like to start by saying that prognosis of multiple sclerosis, we all know, is not uniform. When you see a patient with MS, you cannot really predict what's going to happen to that patient. And I was lucky enough to become a consultant in 2005, and before that I was very lucky to work with some very eminent neurologists who I had great respect for. And looking back at the way they practiced is extremely different to the way we practice today. So patients that were seen with some sensory symptoms would have been examined and usually dismissed. Very few of them would go on to have MRI scans, and very few of them. So it's only the more aggressive patients that used to be diagnosed when I was a registrar or before. And in my days as a consultant, just in Bristol, when I started in Bristol, I was the 6th neurologist. We're now up to 18. We had 1 MRI scanner. We're now up to 4 in Bristol, and many more dotted around the country, dotted around the area, including private scanners. And the resolution of MRI scanners has changed quite drastically. So we've gone from 0.5 Tesla up to 3 Tesla, or even more now. And we have much lower thresholds for imaging. When I was training, there was no way a GP could get access to an MRI scan, whereas now it's fairly common. So I believe, and I think it's brought out in the clinical trials that we all look at, that the relapse rate in the clinical trials and the placebo arms have dramatically fallen. And I think that we're looking at a different population from the populations that we analyzed in natural history studies many, many years ago. Oops. And on top of that, we've got increased public awareness. The patients are very much aware that multiple sclerosis is out there now, which in the past probably wasn't so much the case. And if you Google just about any neurological symptom, you come up with multiple sclerosis. And I Googled up fatigue, which is one of the most common causes of GP or primary care physician consultations. And on the top of the first page comes up the MS Trust. So fatigue is there. And I was very interested to see recent studies looking at headaches as a primary cause of the start of multiple sclerosis. So I wouldn't be surprised that in 3 or 4 years' time when you Google headache, that the MS Trust comes up there too, pushing us to scan more and more patients. We're scanning more and more headache patients as well. So I'd like you to remember that MS, the prognosis is certainly not uniform. And this concept of radiologically isolated syndrome or subclinical multiple sclerosis, I would stress, is not new. It's not a new concept. It's been around, it's in the 60s and 70s and 80s in the autopsy studies. So in the 1960s and 1980s, in autopsy studies, with people who had no neurological symptoms, had no past history of any neurological complaints, and it was not infrequent to find that patients had demyelination on autopsy after the patient had died. So it's suggesting that in the 70s and 80s and earlier, undiagnosed MS was common. And I was stressed they had a good long-term prognosis because these patients died with multiple sclerosis on autopsy but had never presented with neurological symptoms. So I think benign multiple sclerosis has had a real bashing over the last 10 years or 5 years, but one has to remember that actually benign MS does exist. It is out there. And I think this partially explains why we're seeing an increased incidence and a better prognosis of the MS patients we're seeing in clinics. And we were just talking over lunch about the number of patients we have on low efficacy therapies, deemed as lower efficacy therapies, injectable therapies, who've been on them for a long, long time and have done remarkably well. And one does question as to whether or not it's the effect of the drug or whether they would have done well anyway. And the RAS prevalence, when you look at scans, is not that dissimilar to the post-mortem studies in the 60s and 70s. So we're just finding those patients earlier. But there's one key difference, obviously. The patients with RAS are still alive, okay, with autopsy patients are not. So it's big difference. So one has to look at, well, what's the natural history that we have so far on RAS? And I think the best study for this, having looked at the literature, is from a consortium of North American studies and European studies, of which the principal author was supposed to be my antagonist today. And I think the key figure from that is that after 5 years, 1/3 of patients had a clinical event. So I want you to hold on to that. So I would argue to you that this is a relatively favorable prognosis compared to the MS patients, the old natural history cohorts, and the MS patients that you see day to day in clinic. And importantly, the most important people I think you need to identify for RAS is those patients who are going to develop progressive multiple sclerosis, because they're the ones that are going to have worse disability, and only a tiny fraction, 3%, develop primary progressive MS in 5 years. And by that time, you had a mean age in that cohort of 42. So that's above the old cutoff, where mean onset was 40 in previous studies. Now, there was a higher risk found in patients who are of male gender, of younger age, and with cord involvement. But interestingly, there was no increased risk if there was gadolinium enhancement on baseline scans. There was no increased risk if there was infraterritorial lesions. And interestingly, CSF oligoclonal bands in this particular study, again, there was no predictor of developing multiple sclerosis within 5 years, although a subsequent study has indicated that perhaps oligoclonal bands might. So I would say that this is quite surprising in this group of patients because you've alerted these patients. Patients have come to you. Well, what happens in Bristol is a patient will have an MRI scan by a GP or by another neurologist, and you could argue whether or not they should have had that scan. They then come to you, and they are very worried. They are very worried. So they've been, they're on heightened alert for new neurological symptoms. They're on heightened alert that they could develop multiple sclerosis, an awful condition. You know, everyone knows about multiple sclerosis. Everyone visualizes those patients in a wheelchair or worse. Yet, despite heightened awareness, only 1/3 of patients go on to have a relapse or develop progressive MS in 5 years. And I would stress to you, if you're thinking about treating patients with RAS, have you got the data to back you up? And I'd ask you, you don't. I agree that it's potentially an attractive proposition to treat early, and this is what we've been told year after year after year for the last 10 years. Treat early, treat early, treat early, and we've seen clinically isolated syndrome patients. We're moving more towards treatment of that. But I would argue even with that cohort, if you look at the long-term prognosis of CIS patients, it is not the same as patients who have got clinically definite MS, and RAS patients are down even further. So one can't really extrapolate using the DMTs, I don't believe, to this particular cohort. And the only data to date looking at treatments in the Okada study was that actually patients did worse. So patients who were given DMTs, of which there were 73, 45% of them went on to have a clinical event, whereas those who didn't receive treatment, only 31% did. Now, this was not a randomized control study, but probably does indicate that the neurologists who were looking after the patients somehow could tell that their patients were more likely to get multiple sclerosis. But we're not looking at 100%, we're still looking at 45%. So I would say to you, as neurologists, that if you're going to treat patients with RIS, you're leading with your heart, not with your brain. And I would like to remind you all here that you are mostly neurologists. So you should lead with your brain, not your heart. So that boils the question, should agents be administered to patients before there's any demonstrated benefit? Now, having been through a mortality audit of a patient of mine who died from one of the disease-modifying treatments, which was a very harrowing procedure, I had evidence to say, well, they met the criteria. There was evidence that you could treat. The patient was aware of that, and I could back my decision up. What I would say to you, if you treated a patient with RIS and something went wrong, all right? Unfortunately, things do go wrong with treatments, whether it's aspirin, whatever it is you use, things will go wrong. If you treat enough patients, things will go wrong. And then I'd like to, you have to think, how are you going to defend that position when you step up in that mortality audit when there's no evidence to back up your decision? Worse than that, if you stand up in court, how would you defend it against a barrister or a nasty medical legal specialist like myself? All right? So I think it's very important you think about these things. There are, however, ongoing clinical trials, and I would argue that we should wait until we have good evidence to support treating patients or offering patients with RIS DMTs. And there are risks. There are risks of treating patients with RIS. First of all, misdiagnosis. There must be something funny about this population because only a third of them go on to have an event in 5 years. So I'd argue that we're probably misdiagnosing some of those patients. They probably don't have multiple sclerosis. The conversion rate to multiple sclerosis in that cohort seems remarkably low. Therefore, if you were treating, you're going to be mistreating 2/3 of those patients. And as I said earlier, I don't believe that benign MS, I do believe benign MS exists. The autopsy studies, the RIS studies, and the CIS studies, I believe, prove that. And you have to remember that when you're seeing these patients. Then there's the boring financial costs. So the CARDA group recognized that a third of patients would go on to have an event after 5 years. In the UK, according to our pharmacy department, scleroderma acetate is the least expensive option, and it's said to reduce relapses by approximately a third in RRM and relapsing remitting MS patients. And whether you can extrapolate that or not to RIS patients is uncertain. But if you did, you'd have to treat 9 patients for 5 years to prevent potentially one clinical episode, of which the predominant episode is going to be a sensory relapse, of which the patient will get better from. Now, in the UK, unlike the Americans, the costs are hugely different. We're obviously very privileged. I mean, our cost for scleroderma acetate is about £6,000 a year, which I think is about a seventh of what you're paying in the United States. An incredible difference. And why we're not seeing more American patients coming over, I've got no idea. But you'd have to treat 9 patients for 5 years in the UK to prevent one episode. It would cost you £300,000. Now, when I go to my managers and say, I want more money, what they tell me is, well, if you're taking more money for you, where am I going to take it from? I've got to take it from somewhere else, because the NHS is not a finite, infinite resource. So that money could pay for 44 knee replacements, could pay for 320 cataract operations, and probably more relevant to the group in this room, prostate operations. And then there's the emotive and personal costs of treating patients with RIS. There's all the monitoring, which is a hassle for us, but it's a hassle for patients. Patients don't like having bloods done. Coming up to the unit is difficult. You can't park. MRI scans, a lot of our patients don't like having MRI scans. Coming to clinic to see me, people don't like to see me. They don't want to see me. And you're labeling them. You're giving them a label that you're going to maybe develop this horrible disease of multiple sclerosis, and that's a big drain on patients, just waiting for something to happen. And in other countries, probably more so than the UK, you've got the potentially increased costs of insurance and other health insurance premiums. And if you work out the number of injections, other speakers were alluding to this before, that quality of life is affected by your treatment. So you'd have to take 7,000 injections with 3-weekly glutamate acetate to prevent one relapse. 7,000 injections. So if you are going to start a patient on a treatment, I think it's worth talking about the burden of how much you're going to have to take before you'll get any benefit. And we have to remember, as we've heard, that any of the treatments that we've given, including stem cell therapies, they're not a cure. And there's potential long-term risks. Then I would ask you the next question. If you did treat the patient, what's going to happen? So by far the most likely statistical event outcome is that the patient will do well, right? So how long would you keep the treatment going? Would it be 1 year, 3 years, 5 years, 10 years? How long? 30 years? If you wanted to stop the therapy, would the patient let you? This is one of the most difficult discussions I have in clinic. In the UK, we have these forms that if you fill out, once they hit an EDSS of 7, you're supposed to stop the therapy. And that's one of the most difficult consultations I have in clinic. And it's going to be the same with this cohort of patients. How often would you scan those patients? If you saw new radiological lesions, we heard about escalations of therapy. Well, that raises an increase of risk. And if you treat patients who are likely to do well anyway, this is the ideal marketing population, hence why I'm probably standing here today. This is a pharmaceutically sponsored event. And if you extrapolate the prevalence of RIS in patients who have MRI scans in Bristol, we would find, if we scanned everyone in Bristol, between 600 and 7,000 patients out there who have scans that look like demyelination. That's a lot of patients, that's a lot of money. So there's a lot of unanswered questions. I think we will have more evidence in the next few years, and maybe the situation will change, but I don't believe at the present time we have enough evidence. One could argue about the risk of MRI lesions and fatigue, MRI lesions and cognition. Maybe RIS patients are affected. We just don't see it. But the evidence for that is pretty slim. So, would I like to treat an RIS patient I felt was at risk of developing multiple sclerosis? Well, of course I would, if I knew they were going to be at risk of developing multiple sclerosis, but we can't tell that at the present time. I would also like to point out that we have to have something that's affordable for the National Health Service, and if we are going to start treatment, we need clear guidelines as to how long and what we'd stop and how often we'd scan and would we escalate therapies rather than just being a maverick and going ahead and doing that treatment. I suspect Gavin will talk about a middle ground. There are some factors that do potentially increase the risk of developing multiple sclerosis, the presence of spinal cord lesions, younger age, male gender, and in more recent studies in smaller groups, potentially neurofilament levels in the CSF perhaps indicate an increased risk. So perhaps there is a middle ground. But I was going to finish the talk with a quote from Okada's paper, which basically sums up what I've been trying to say, that in the studies to date, treatment RIS has failed to show any benefit. The studies to date have bias, so we can't interpret much from that. And although there is the emotive decision to start treating early, as we've been taught over the last 10 years, we still don't know if it's the right thing for your patient. Thank you very much.